Hi everybody. It's such a challenging question for a presentation, to be perfectly honest. And to be honest, I actually changed the presentation quite recently and sent actually a different one, and I'm now regretting that. But just a bit of background about me and the work I do linked to this particular presentation, because I think it's really important that I spell out the context here in terms of some of the messages I'm going to share with you over the next few minutes. As Ashley says, I actually work for NHS England, and I am responsible for commissioning and for policy development. But it's really interesting how NHS England does its commissioning and policy development these days, because it's all clinically led. So I work with a bunch of clinicians who sit on the Children's Cancer Clinical Reference Group, and a few colleagues are here today. So it's not commissioners, if you like, sitting in dark rooms with accountants who actually come up with stuff these days. It's actually clinically led, which is an important context to addressing this particular question. It's an interesting question too, because it's a question that we get asked for information about all the time, especially from MPs and freedom of information requests. And to be perfectly honest, it's really difficult to actually answer that question. We do know that parts of children's cancer are excellent, but we actually haven't got all of the answers across all of cancer services. And one of the things that Andrew mentioned in his talk right towards the end was this need for a collaborative network approach to children's cancer. And to be perfectly honest, I think that's what we need to do in terms of getting to address this question. Children's cancer services aren't huge. We actually deliver children's cancer services through 14 principal treatment centres and a number of shared care units. What we actually do need is for all of those hospitals to be working as a single unit, if you like, within a network, so we can actually start to address some of these questions about is it good together. What we haven't got is a national strategy for children's cancer. So therefore it's actually difficult to actually work through what our priorities are as a network, as a network of colleagues who are actually working with children's cancer every day, and kind of work through where we need to put investments, where we need to put particular strategic areas. It's just terribly challenging. We actually do all of what we do through silos to some extent. So there is a need to pull some of what we do together. And the reason why I'm saying all of that too is because we quite recently have been involved in the cancer task force work. I don't know whether colleagues in the room are aware of that, but it's a piece of work that's been coordinated by CR UK and chaired by Harpal Kumar. And Harpal Kumar asked the Children's Cancer Clinical Reference Group and a whole other bunch of children's cancer experts from across the country to meet with him to talk about how we can actually improve children's cancer services. And it was a really interesting session in many respects, because what we actually came to in the end was that there's a real need to make sure that we've got access to really good information all of the time, and that we actually spend a lot more effort, resources, and input, if you like, to actually making sure we secure research and data infrastructure right across the children's cancer service networks. So not just through CCLG and not just through NCIN and those groups, but we actually work with hospitals themselves to make sure that we've got the right infrastructure in hospitals to enable us to support the need for pulling data in and analysing data. That's a long preamble in terms of how do we know it's good. So let's just have a look at some of the information that we know about. And I'm going to be teaching my granny to suck eggs here, because you'll have seen all of this before. It's just a bit of context before we get into some of the detail that we shared with the Cancer Task Force. Because I think it's really important that we actually do share with you what we are saying to the Cancer Task Force. And the last couple of slides that I'm going to share with you are about data, but they're also about some of the wider worries that we've got. And I'm going to work through some of them too, because I just think it's useful to share it with a group like this. So we know that children's cancer is rare. We know how many children actually develop cancer every year, and we know where all of the challenges are in relation to that. We also know that the majority of children with cancer are treated within clinical trials, and it's something like 67-68% at the moment, so it's quite high. One of the challenges that the Children's Cancer Clinical Reference Group set within its service specification that it wrote for NHS England that went into contracts with hospitals was to actually try and get 80% of children on trials. So we still have a bit of a gap there with that. But in terms of this thing about how do you know it's good, well, we do know that more children than ever before are surviving cancer. We know that at least 15,000 more children have survived for at least 10 years after being diagnosed. We know that 5-year survival has more than doubled since the late 1960s, and at least 33,000 people walking around today being diagnosed with a childhood cancer and survived for more than 5 years. So all of these indicators are great, and they're all pointing towards something which smacks of greatness, never mind goodness. 3/4 of children with cancer are now cured, again compared to a quarter in the late 60s. And for some solid tumour groups, we have excellent outcomes. For leukemia, our outcomes are some of the best in Europe. And outcomes for allogeneic stem cell transplants, again, are some of the best in Europe too. And I think this last bullet point is quite an interesting one. The UK does have a long-standing history of paediatric enhanced data collection, which is really brilliant. But it is a big but, we still have huge gaps running across the way in which we actually collect data and analyse data. And to some extent, the data world has got worse over the last couple of years for us. We need to think about that in terms of next steps. So here are some of the challenges, and these are some of the challenges that we shared with the Cancer Task Force. The 5-year survival for all diagnoses is 1% to 2% less than the European average, and up to 4% behind the best in Europe. For children with brain tumours, we're up to 10% below the best in Europe and in America. And we do know that patients with metastatic neuroblastoma and soft tissue sarcoma still have inadequate survival rates. We also know that we still have some huge problems around diagnostic delays and the way in which we actually interface with primary care and the role of GPs within diagnosis. We still have some fault lines running through that. And those fault lines, to be perfectly honest, have been running through that system for years now. So there is a need for us to collectively look at how we can actually resolve some of those issues. And I know there's been some attempts at doing that, but again, it's not linked to a national strategic approach to that. It's one of the big problems that we've got, and we're not addressing it strategically, I don't think. Molecular diagnostics are not generally available to clinicians unless children are in trials, and further development in clinical trials in brain tumours is needed in order to ensure wider access. One of the other big challenges that we've got, and isn't bullet pointed on there though, is this thing about kids who aren't on trials. That for us is a huge gap in terms of knowledge, information, and outcomes, if you like. We know very little about those children. So if we're actually talking about how do we know it's good, we actually need to start making sure that we start collecting information on kids who are not on trials. So we can actually start to profile children's cancer right across the board. So we've got some huge gaps here in terms of our knowledge. These are some bog standard bullet points and statements, to be perfectly honest, but I'm going to share them with you anyway, because I do think these are gaps that we've got, and unless we start addressing some of these gaps linked to information and linked to finding out what parents and children actually think of our services, then we're actually not going to cover everything in terms of how good do we know our services are. So that first bullet point, where we've got cancer patients under 16 are excluded from the National Cancer Patient Experience Survey. I don't know why we do that, but we do, and we need to start addressing that pretty quickly. I know some hospitals do address that, but again, finding out from people who use our services is key to actually improving them. So we've got a bit of a challenge there. The second bullet point is linked to the point I made before in terms of children who aren't on trials. But it is an area that we do need to focus in on. And it's something that the Clinical Reference Group has raised for quite some time now. And it's something that, again, we shared with CRUK and the Cancer Task Force at the session that we had with them. Kids who aren't on trials, in terms of gathering information about them, does require hospitals to have in place the right infrastructure to enable them to collect data about those kids. And that then goes back to how we resource children's cancer services. So these issues, whilst you actually look at them in a bullet point, look fairly straightforward in terms of, well, why don't we sort that out, do have a resource implication to them. So that I'm not suggesting for 1 second we can kind of sort these things overnight, but to be perfectly honest, we are going to have to start addressing some of these areas. For children, teenagers and young adult cancer services, access to data generally desperately needs to be improved. We do have some significant information and data gaps. And we're unable, I think, with confidence to describe cancer outcomes. Again, going back to the requests that we constantly get in about how well are we doing in terms of children's cancer. What we can point to are pieces of research, but what we can't do is really point to children's cancer per se and say, actually, this is how it's performing, this is how good it is, this is what children are experiencing, this is what it looks like over here, this is what it looks like over there. We do have some of that analysis going on, but not a rounded analysis. What we don't do is we don't report on patient outcomes and patient and family experiences by tumour type and hospital site. And again, going back to this statement that I made at the very beginning about, wouldn't it be really good if we had a network of hospitals who were part of a single service, where we could actually do that, start comparing and contrasting. We do think that would contribute in a really positive way to improving cancer outcomes. And we also know that to enhance learning, there should be a mandatory requirement for a confidential inquiry into every treatment-related death. And again, we haven't got that in place yet. But again, some colleagues within the CRG, Nick Goulden especially, is constantly talking about that. You just raised your eyebrows there. It's just been approved, actually. Has it? Yes. Excellent. There you go. So we do have huge gaps and challenges to overcome in order to enhance levels of data and clinical information and outcome information. We do need to start getting a commitment from Public Health England and the National Cancer Information Network with the right resources in place to enhance the level of clinical information. We're talking about risk stratification factors, relapse progression, all that kind of stuff, family history. Again, talking to colleagues from NCIN and colleagues from Public Health England, we have recently restructured how we do all of this. And the feedback that we're getting back from colleagues is that we've actually weakened how we actually go about gathering data. So there is a need to look at that again and again work through how we can improve that. I've mentioned this next bullet point about all aspects of cancer care for children, teenagers and young adults should be more research competent, supported by the relevant infrastructure. And again, that's about hospitals being research competent or more research competent and having the resources to actually put those things in place. And there is a need to influence policy to enable data on rare cancers that's not anonymised to be sent to the central analytical team from all UK registries to enable a UK-wide analysis. And again, that hasn't happened since 2002. So what we've got there is a whole load of good news in terms of how good children's cancer services are. Things are definitely pointing in the right direction. But we've got some very basic things that we just need to sort out. And access to data and how we go about getting access to data and putting the right infrastructure in place around data are areas that we do need to focus in on. I'm sorry about the size of the words on this particular slide, but this is the stuff that we shared with the Cancer Task Force. And I think it is helpful to just go through some of them, just to give you a feel for the stuff that we actually shared with CR UK, because we do need to get these things sorted out. And there are some issues in here about practice, but there are some issues in here about data and data collection. And quite often, one informs the other. So this thing around getting the infrastructure and the data processing right is really important. So let me just go through these. Teenage and young adult patients with cancer have been called the lost tribe, as their outcomes are poor. And again, some of the data that we've got access to tell us that. They're not being recruited into clinical trials, and they do have specific unmet needs. And this thing around transition is a really important area. Children and young adults are actually falling in between different types of services as they kind of move through into adult cancer services. That second bullet point is all around how we actually configure services and the relationship between principal treatment centres and paediatric oncology shared care units, and whether or not we actually need to look at how we manage all of that and how we actually network all of that. And again, it goes back to that very beginning statement about the need for children's cancer services to be part of a single network. Third bullet point is around diagnosis. We've been through that. I mean, we know what the issues are there. That fourth bullet point is around the support and development of and access to clinical trials. And yeah, sorry, I'm being told to hurry up and I'll move on. Let's just skip through a couple of them. I'll move to this last slide. So yes, there is a need to actually kind of fix and work through some of the organisational issues that we've got in terms of children's cancer services. There is a big effort that needs to be put into teenage and young adults. But we do need to get into a different mindset in terms of how we approach pulling children's cancer services together, linked to the need for sorting out these significant information and data gaps that we've got across the system. Because we actually do think that's a detriment to improving outcomes. And unless we actually focus in on some of those issues, we aren't going to be able to move some of these things forward collectively. We might get some improvements in silos, but what we won't get is a strategic move forward or a strategic improvement linked to the things that we've agreed should be sorted. Sorry, I'm being told to hurry up, Ashley, so I'm sorry about that. Okay, so that, folks, is where we are in terms of children's cancer from the CRG and the Cancer Task Force. Thank you.
Thanks, Anthony. I don't want to...